Okay, good afternoon, everyone. Thank you for joining the second session in our age-friendly geriatric tele-echo series for the Primary Care Network at UC Davis. The series has been organized for you by UC Irvine's Division of Geriatric Medicine and Gerontology and our Geriatric Workforce Enhancement Program and our academic partners at UC Davis. We'll go ahead and get started. I think people are kind of registering and joining a little late, but feel free to introduce yourself via the chat as we go along. Today's agenda is going to start with announcements and introductions, and we're going to follow that up with our didactic presented by Dr. Gervich on avoiding polypharmacy for the aging patient. Then we'll move forward in our case presentation and then closing and reminders. I think you guys are all muted, but if you ever have any questions or want to speak up and talk about the case, feel free to unmute yourself at any time. Just maintain confidentiality when speaking about patient cases and just respect others and their opinions. This session is CME accredited. Each session is 1 hour and is 1 CME credit. If you attend all of our sessions in our series, you will receive 4 credits. Make sure you fill out the CME form that is sent to you after each session. This is just our general grant disclosure. If you are joining us from UC Davis, please go ahead and feel free to introduce yourself in the chat function with your name, your role, your site, and location. We'd love to see where you're joining us from. And then we'll go ahead and have our hub team introduce themselves today. Dr. Gibbs is not able to join us today, but I'm the project manager for our Geriatric Workforce Enhancement Program, and my name is Nika Seville, and I'm here in Orange County, California. We can have Dr. Gervich go ahead and introduce herself.
Hi, I'm Tatiana Gervich. I'm a clinical geriatric pharmacist. I teach at USC School of Pharmacy, and my primary practice site is at UCI Senior Health Center, where I help take care of older adults.
Wonderful. Thank you, Dr. Gervich. And Dr. Sagal.
Hi, everybody. Welcome. I'm Sonia Sagal. I'm a clinical professor in the Department of Internal Medicine and the Division of Geriatrics and Gerontology. And my practice site is also at the UCI Senior Health Center in Orange.
Great. Thank you, Dr. Sagal and Dr. Campbell.
Hi, everyone. My name is Dr. Sarah Campbell, and I'm a family nurse practitioner. I work on campus at UCI Student Health Center currently and am a professor in the School of Nursing.
Thank you for joining us, Dr. Campbell. Okay, we'll go ahead and get started on our didactic. Dr. Gervich, you can go ahead and take it away.
Okay, so today we're going to talk about polypharmacy in the older adult. Next slide. We're going to talk about just basic usage of medications in older adults, define the term polypharmacy, talk a little bit about the age-friendly health systems and how that's affected by medications, talk about strategies to avoid polypharmacy and review some criteria that we often use in managing older adults, and finish with a patient case. So I found these 2 quotes, and they're kind of interesting because they're about 100 years apart. At the turn of the previous century, Sir William Osler was really against using medications and was advising patients not to use them. And, obviously at the time he had at his disposal not a lot of options, but heroin was widely used, cocaine as well. But the quote underneath that is by a geriatrician out of the Bay Area, which basically kind of says the same thing. Older adults would be a lot healthier if they stopped taking half of their medications. So unfortunately, in the intervening 100 years, we haven't made much progress in limiting or eliminating polypharmacy from existence. And that's, I think, partly because we keep doing things the same way. So hopefully this lecture will help kind of guide us in the right direction. Next slide. So we're always looking at numbers and how many medications older adults take, And clearly, there's an increase in medication usage with age because we tend to accumulate medical problems, and often those require pharmacotherapy. So we're always looking at numbers, right? So the trigger number for polypharmacy is 5. So when somebody's taking 5 or more medications, they're at risk for polypharmacy, and this graph illustrates the increase in older adults who are on 5 or more meds. Now, 60 plus isn't even geriatric. In our clinic, the average age of our patients, I think, is somewhere in the 80s. And I see a lot more meds than 5 on the list. So it's not just a number-driven definition, so that's something to keep in mind. Lots of older adults are going to be on 10, 15, 20 different medications taken at the same time, and that's when some of the problems arise. Next slide. So medication-related problems are generally pretty expensive, and they cut across all healthcare settings. 27% of adverse events are reported in primary care offices, 37% reported in nursing homes, lots and lots of problems in hospitalized patients, including adverse drug events and drug interactions and all of that. So it's a problem that sort of cuts across all healthcare settings and needs to be addressed everywhere. Next slide. If we think this is just a problem in the United States, it's not. This is data out of England looking at adverse reactions following a hospitalization. So this graph shows that 72% of patients had issues with an adverse drug event post-hospitalization. And the primary reason for that was not a mistake made by the patients or the caregivers or non-adherence. That only accounts for about 14% of the cases. The vast majority of problems is an adverse reaction from presumably a medication that was inappropriately prescribed, and about 13% were as a result of more than one medication inappropriately prescribed. So those numbers are pretty startling. Next slide. So this is what we typically see in our geriatrics clinic. This patient came in for a geriatric assessment program with our team, which includes a physician, a psychologist, a dietitian, an occupational therapist, and myself. And they brought in 3 bags full of medications. This picture is blurry for a reason. I think this creates a lot of confusion for the patients themselves. How do you take all this stuff on a daily basis? How does a caregiver administer all these medications? And how does a provider go through this giant med list at every visit when you've got a 15 to 20 minute follow-up appointment scheduled? So there's a lot of potential for confusion, misprescribing, overprescribing, and just confusion on the patient's part of what to take when. Lots of over-the-counter stuff as well as prescription meds. So this is a really typical picture for a lot of our patients. Next slide. This is a picture I took in a patient's home. At USC, I'm part of this interdisciplinary teaching effort where we take students, or used to take students prior to the pandemic, to their homes and talk to older adults about all kinds of different things related to their care. On this visit, we were actually talking about nutrition. This patient was a gaunt, underweight gentleman who was having trouble getting food. He didn't have enough money to buy food. So when that came up, we immediately went into his kitchen and opened up his pantry. And this is what we found. So his pantry was full of herbal products. And I know the case today that we're presenting at the end has to do with herbal usage. I think this is really appropriate. When we looked at individual bottles and looked at the ingredients, it turned out obviously there was lots of duplication, overusage of vitamins, lots of potassium in a lot of these preparations, which was probably equivalent to, a prescription strength potassium formulation. Down on the bottom here, I don't know if you can see, there are a bunch of tinctures and vials. So the thing with tinctures and vials is liquid herbal products is there's a lot of alcohol in them. A typical tincture has about 30 to 40% alcohol content, and so if he in fact took all of these vials down here, that would be equivalent to 2 to 3 alcoholic beverages in a day for him. So that's an additional concern. When you look over to the other side of the slide, he's on 4 medications. by the number definition, that's not even polypharmacy. So he's got an activating antidepressant here, followed by a long-acting benzo. That potentially could be polypharmacy because that's a medication cascade. Is Wellbutrin activating him so much that he needs clonazepam to calm down and to help with sleep? So that's a question. But this usage of herbs is clearly polypharmacy. And how do you approach it in someone like that? You can't just tell him to throw it all away and buy nutritious food instead. You have to do it very carefully, kind of explaining to him where the duplication is and trying to get rid of a little bit at a time, whittling down this list gradually as you get to know the patient. Next slide. Over-the-counter market is full of medications that older people should not be using. On top of this slide, these are all high-risk medications that have anticholinergic medicines in them that could potentially cause confusion, sedation, and increase the risk of falling in your patients. Down here, there's some stuff that older adults commonly use, like Advil and Alka-Seltzer. Alka-Seltzer is full of sodium. A typical tablet of Alka-Seltzer has about 800 to 1,500 milligrams of sodium, depending on the formulation, which would put you over the top for, if you're on a salt restriction for hypertension or CHF. Advil can also obviously increase blood pressure and cause fluid retention. So lots of these things have to be looked at very carefully, and we just don't have time for it. Statistics show that 25% of patients do not tell their doctors about their over-the-counter medication usage, and most physicians don't ask just because they don't have time, or they really don't know how to address a lot of these concerns. So it's really important to look at what they're taking over the counter, review it, and get rid of it if necessary. Next slide. So again, polypharmacy, what is that? It is actually the use of unnecessary medications regardless of the number of medications being taken. So it's not just a number-driven definition. Again, I've seen lots of very complex patients who are on more than 20 meds, and they're so medically complex that they really do need to be on all those 20 medications. And I've seen much shorter med lists that really could be cleaned up and diminished because there's lots of duplication and kind of inappropriate prescribing going on. So it's really, polypharmacy is really taking more medications than it's clinically necessary, and it's very patient-specific and patient-centered. Anybody who's taking 5 or more medications is at risk for polypharmacy, so you should really, whenever you see a list of 5 or more meds, you should really look at the list, make sure it's appropriate, and get rid of some things if they're not appropriate, or else move on. Next slide. So the fastest way to get into a polypharmacy mess is through medication cascades. Medication prescribing cascades are a drug-induced adverse event which mimics symptoms of another disease which is being treated with more medications. So here's an example of one: donepezil given for Alzheimer's disease for memory. It's a cholinergic agent. So it increases acetylcholine levels, and one of its side effects would be urinary frequency because it increases acetylcholine levels. Urinary frequency in older adults often presents as incontinence because they can't make it to the bathroom in time. And then you end up treating that with potentially an anticholinergic urinary antispasmodic, which increases the risk of confusion and cognitive decline. And again, you're using a cholinergic agent for Alzheimer's disease, and you're using an anticholinergic agent for incontinence, and these two medications just are kind of butting heads due to their mechanism of action. So that would be an example of a prescribing cascade. Next slide. Another common thing we see in older patients is, amlodipine for hypertension. One of its very common side effects is lower extremity edema. How do you treat edema? Usually with a diuretic, although the mechanism for amlodipine causing edema is actually not fluid overload, but kind of fluid redistribution. But we often treat it with diuretics nonetheless. So hydrochlorothiazide, for example, that'll increase the frequency of urination in that patient, potentially cause incontinence and bring you down the cascade that we just talked about. So giving them an anticholinergic, which can cause confusion. A drop in blood pressure from that additional antihypertensive medication can also increase fall risk and dizziness, cause all kinds of electrolyte imbalance as a result. So we have to look at the potassium, magnesium, calcium, whatever, uric acid levels. The other side effect of amlodipine that's less well known is sometimes, it's a smooth muscle relaxant, so sometimes it can cause a lower esophageal sphincter to get too relaxed, and that can contribute to heartburn. And what do we do for heartburn? We use proton pump inhibitors. Long-term usage of proton pump inhibitors is associated with an increase of fractures, reduced calcium absorption, reduced magnesium levels, B12 levels go down. So lots of other problems resulting from the use of PPIs. C. diff infections are common. So you're kind of taking the patient down the path of more problems down the road if we prescribe PPIs long-term. Next slide. So when you look at a geriatric patient and you look at these common geriatric syndromes like memory loss, weight loss, confusion, depression, dizziness, drowsiness, all these could be new onset medical problems. But when I look at them as a pharmacist, all I see is drug side effects. So I think if we don't think of these things as drug side effects and look at the medication list and see if any of the medications the patient's already on can be contributing to some of these problems, we're doing a disservice to our patient. If all we do is look at these as medication side effects, we're going to miss a bunch of important medical conditions that will need to be worked up. But I think there has to be sort of a blend of this, looking at this as potential medication side effects as well as potential medical problems. So a physician said, Jerry Jerwis is a physician, I think he might have been married to a pharmacist, but he said any symptom in an elderly patient should be considered a drug side effect until proven otherwise. Next slide. So in this age of age-friendly health systems, we're looking at very patient-centered care, and the 4 pillars of the age-friendly health systems that have been identified are what matters most: mobility, mentation, and medication. So finally, we're focusing a little bit more on appropriate prescribing, getting rid of some of the high-risk medications, and looking at the overall pharmacotherapy options that we have for patients and kind of picking more appropriate choices. Next slide. So from my perspective, medications really can impact each of the pillars. So in terms of what matters most, polypharmacy can really worsen quality of life. First of all, you're having to take a boatload of medications on a daily basis. You have to structure your day based on how you're going to take your Lasix and whether or not you're going to go to lunch the days you take it, for example, because you might have to stay close to the toilet and not be able to interact with your community. Cost could be a major issue when you're dealing with a lot of medications. All those copays do add up and can really impact the patient's quality of life from a financial standpoint. Obviously, when looking at the medications as a pillar, we want to get rid of high-risk meds and we want to deprescribe whatever is not absolutely necessary for our patients. In terms of mentation, depression has to be treated effectively with the right drug at the right dose. You want to manage cognitive decline and make sure medications aren't the cause of the cognitive decline the patient is experiencing. In terms of mobility, medications can contribute to falling. They can contribute to muscle pain, fatigue, which will also impact mobility. And obviously dizziness is a common side effect of a lot of meds, so looking at the med list to see if anything can contribute to the dizziness and impairment of mobility is really important. So medications kind of fall into all of those categories in one way or the other. Next slide. So deprescribing has been a very popular thing to talk about, especially in the midst of this pandemic. In the very beginning of it, we really made a dent looking at nursing home patients, for example, to see what exactly they need routinely and urgently, and what we can kind of get rid of to limit patient contact and limit transmission of COVID, obviously. But now that we're getting a better handle on the pandemic, it's still a good idea to review the med list and get rid of anything unnecessary. So deep prescribing is a very organized, rational process when you're trying to get rid of a single medication at a time, monitoring the patient while you're stopping the medication or titrating it off, making sure that the patient is doing better as a result of this deprescribing, and only reinitiating that medication if it's again becomes necessary. But deprescribing is always encouraged, especially when you have patients on long medication lists. Next slide. So we've got a lot of different criteria we look at when we determine whether the drug is appropriate for an older adult. The Beers criteria is just one of those. Initially it was developed in the 1980s, and it was just targeting the skilled nursing home facilities, because at the time patients were seriously over-medicated in those places. Medications were used as chemical restraints, and you had hidden cameras showing patients slumped over in wheelchairs, falling out of beds, because they were just over-medicated and ignored. But over the years, the Beers criteria has been adjusted to really apply to any healthcare setting. So now it's used in SNFs, ambulatory care settings, and in hospitals. And it's really a tool for clinicians to kind of look at some of these higher risk medications to see if the patients really truly need them or if they can be gotten rid of. So there's always this risk-benefit analysis that goes into deciding whether to use any medication, whether it's high risk or not, and the Beers criteria kind of guides you in that process. Next slide. There are other criteria out there. The stop and start criteria were developed in the early 2000s when the Beers criteria was about 10 years out of date and kind of became clinically irrelevant at that point. So that the British, I think, came out with a stop and start criteria, which is really similar to the current Beers list. It's a list of medications that should be used in patients to improve quality of life, and it's also a list of medications that should not be used because they contribute to adverse events and outcomes. There's also something called ACOVE, which is Assessing Care of Vulnerable Elders, and this is just a really rational, systematic approach at looking at medication. So documenting whether or not medication therapy is appropriate, educating patients on how to use each medication and why each medication is being used, maintaining a current medication list, documenting response to therapy, and just doing things that just make common sense when you're dealing with older patients. Next slide. So let's take a closer look at the Beers criteria. The last time it was updated was in 2019, so it's a few years old now. I think the next iteration of the Beers criteria should be coming out next year. But this slide is taken directly out of the Beers list, and it just lists all the anticholinergic medications we have that should be used with great caution, if at all, in older patients. This is sort of the bread and butter of the Beers list. This list has been in the Beers criteria ever since its inception in the 1980s. And the reason you don't want to use anticholinergic medications in older patients is because it can cause, in addition to all the known anticholinergic side effects like dry mouth, constipation, urinary retention, and tachycardia, it can also cause confusion. So whenever you're dealing with a cognitively impaired patient, you really don't want to use any of these medications. And some of these actually, a lot of them are, over-the-counter. The over-the-counter antihistamines like brompheniramine, chlorpheniramine, diphenhydramine, they're all available over the counter. So that's another reason why you really want to ask your patients what they're taking over the counter. Some of these things, the antidepressants, the tricyclics, we don't use them much anymore. But something on the list that's interesting is paroxetine. That's an SSRI. It's the one SSRI with a little bit of anticholinergic activity, so you probably don't want to use it in your cognitively impaired patient. In someone who's not cognitively impaired but is anxious, it may be more appropriate. Lots of urinary antispasmodics are on this list. Oxybutynin we know about, but even some of the newer ones, things like trospium, Vesicare, and Ablex, they're all anticholinergic to some extent and should be avoided in patients with cognitive impairment. Some GI antispasmodics that are given for IBS with a predominant symptom of diarrhea can also cause cognitive impairment and should be used carefully. Some of the muscle relaxants that we commonly use for pain should be avoided for that reason. Hydroxyzine, for example, we still use that a lot. It's an anticholinergic that's antihistamine that's still prescription that could potentially be a problem in older patients. So look at this list, kind of review it, make sure we're not prescribing it these drugs on the list too often. Next slide. So the next slide kind of talks about drugs that could potentially be inappropriate. Again, we're looking at things like muscle relaxants, benzos, the Z drugs like Lunesta, Ambien, and Sonata. They can all cause sedation, cognitive impairment, increased risk of fractures and falls. Nitrofurantoin is on the list. If your creatinine clearance is less than 30, it is associated with pulmonary toxicity with chronic use, and it's a problem if your creatinine clearance again is less than 30. If it's a little bit higher and you're using it for an acute treatment for a UTI, that's okay. Antipsychotics should be used very gingerly in older patients. Obviously, there's a black box warning that's related to their use, so making sure that the behaviors we're managing we're not able to manage them in any other way. So this is kind of a last resort drug, only if we've ruled out, non-pharmacologic approaches and other medications. Proton pump inhibitors are on this list, again, for some of the things we already discussed, bone loss, C. diff infections, things like that. NSAIDs, obviously, GI bleed risk and also renal insufficiency risk as well. With insulin, you really don't want to use sliding scale insulin without any basal insulin in place. And personally, I don't like sliding scale insulin. I think it creates a lot of problems for patients to administer it on a daily basis. They're having to stick themselves a lot to check their blood sugar, so a lot of times we try to avoid it whenever possible. Some sulfonylureas are longer half-lives, and they're increased risk of hypoglycemia there. And some of the other things are also on the list, and the reasons are listed here, so if you can look at it on your own time. Next slide. So again, these are some conditions that we need to be careful with, and some medications that can contribute to these conditions. So this is a very kind of broad category: fall risk and syncope. A lot of things that we commonly use in older patients are on this list. So SSRIs, SNRIs, mirtazapine, we're always using these for depression, and as well as cholinesterase inhibitors in our demented patients. So what does this mean? Does that mean we can't use them because they're on the Beers criteria? No, it does not mean that. What it means that we have to choose every medication carefully, start it at a very low dose, titrate the patient slowly, and kind of monitor them carefully as we're starting these medications, and really consider the risk of falling when we're adding these. So if the patient needs an antidepressant and it's going to improve their quality of life and it's effective for them, then by all means use it. But start at a low dose, titrate up slowly, and really monitor for effectiveness. When you've got somebody with delirium or chronic cognitive impairment, you really want to avoid these. Tricyclics, anything with an anticholinergic profile, sedative hypnotics, some antipsychotics should be avoided, and H2 blockers only in the picture of acute delirium. When you've got somebody not in delirium but needing an acid blocker, H2 blockers are actually preferred over PPIs long term. And then when we're dealing with heart failure, obviously you want to avoid NSAIDs and COX-2 inhibitors. Verapamil, diltiazem can contribute to that as well as glitazone and some of these other antiarrhythmic medications. Next slide. Drugs that should be used with caution. So aspirin for primary prevention on the 2019 Beers criteria, There no benefit beyond the age of 70. The most recent guideline that just came out actually brings the age down to 60. So really, we should not be using aspirin in primary prevention in our older patients. Some of these anticoagulants increase the risk of bleeding at 75 plus. So I think that's one of the reasons we usually use apixaban more often in those patients. This is a more problematic thing. SSRIs, SNRIs, mirtazapine, tramadol, and antipsychotics can cause hyponatremia. Yes, it can cause hyponatremia. Sodium will sometimes dip a little bit, so you do want to keep an eye on it, make sure it doesn't dip too much. But sometimes the benefit of prescribing mirtazapine or an SSRI or an SNRI outweighs the potential risk for hyponatremia. And then Nuedexta really should be used only for pseudobulbar affect, not just for general agitation and dementia. Some things have been removed from the Beers criteria just because the adverse event that it was there in the first place for is not limited to an older adult. So any patient of any age is at an increased risk for seizures when they're using bupropion, tramadol, and some atypical antipsychotics, not just older adults. Decongestants and stimulants and theophylline and caffeine can all cause insomnia in everybody, not just older patients, although in an older adult, these symptoms are going to be more pronounced at lower doses of these drugs. Vasodilators can cause syncopal episodes in everybody. In a demented patient, it's actually okay to use an H2 blocker as opposed to a PPI. Again, except when they're in active delirium, then you don't want to use an H2 blocker. And then aripiprazole is no longer the preferred agent in Parkinson's disease psychosis because pimavanserin has been approved for that indication. I have to tell you, it's never covered by insurance. We're always having to do PAs, and even as we do PAs, we go through hoops trying to get that approved. So it's a very expensive medication that's poorly covered by Medicare Part D plans. Next slide. And then there are some commonly seen drug interactions that are reported on the Beers criteria. These are not new, but they're just something to really keep an eye on. So when we start adding medications that increase potassium in our patients, it can really increase the risk of hyperkalemia, obviously. So we often see combinations of ACEs or ARBs with potassium-sparing diuretics, treatment of heart failure or hypertension. But then when we add something like a Bactrim to the mix to treat an infection, that's when you really see an increase in potassium, and that should be done very carefully with lots of monitoring. We're looking to really limit drug cocktails to use in pain management because when we're using 3 or more medications, that really puts the patients at risk for falls, fractures, and more confusion. So, and especially we want to pay close attention to not using benzos in conjunction with opioids, because obviously that increases the risk of overdose. If one anticholinergic can cause some cognitive impairment, multiple anticholinergic can cause more of it. So there's this concept of anticholinergic load that exists. So you really want to limit the number of anticholinergic medications you're using. And then peripheral alpha blockers with loops can increase urinary incontinence in women. That's sort of a known fact. And then when you're using Coumadin, if that's still appropriate, remember all the drug interactions that can happen with it. So just monitor your INRs, check them often when these things are added on an acute basis. Next slide. And then in terms of dosing adjustments, the creatinine clearance cutoffs are usually, less than 30. We really have to watch out for adverse events in medications that are renally cleared. And some cutoffs are less than 60. So gabapentin dosage has to be adjusted when patients are starting to become renally impaired. H2 blockers, we're using them more now, but they are renally cleared. So you do have to dose adjust at 50 mils per minute or less. Next slide. So now I have a patient case. I'm not sure I have time for it. How are we doing on time?
Yeah, I think let's move on to our other patient case,
Okay.
Dr. Grivich, if that's okay.
Yeah, no problem.
Let's see. think, is this a part of the case as well?
That, yeah, the slides are done.
Okay. Okay. Okay, let's see. Does anybody have any questions for Dr. Gerbish before we move on into our case presentation? Okay, well, she'll be here, so if you have any questions, you can type them in the chat, or you can wait until after the case to ask questions. We have one of our fellows here, Dr. June Lee, who is going to go ahead and give an overview of the case she submitted. Dr. Lee, are you on the line?
Yes, I am. So I'd like to.
Okay, wonderful. Go ahead.
I'm sorry about that. But I would like to kind of ask for your help in approaching this patient. So this is a really pleasant 92-year-old female that I met on during Dr. Argami's continuity clinic back in early October. She has a past medical history of hypertension, hyperlipidemia, CKD stage 3B, osteopenia, hearing difficulties, who's taking supplements, and Son is worried about costs. And this issue of supplements just comes up kind of on the side note. So we wanted to kind of see what this person might be taking and to help kind of strategize as well as look at the appropriateness of her medications. So from the chart itself, as well as speaking with the patient, we talked about her amlodipine as well as losartan, which she takes for hypertension, and atorvastatin for hyperlipidemia. She tells me that she is taking potassium tablet, which is at the bottom of this box. Thank you. Potassium that was recommended by her prior nephrologist for her kidney health. And she takes other supplements that she could not really tell me on the spot. So we had our pharmacy team to please help us out, and they actually reconciled from a separate phone call after our visit. And what we found out was an entire list of supplements that she had taken. And it expands into the second kind of box as well. So we'll just go over briefly. It's acetyl L-carnitine, B-complex, evening primrose oil, fish oil, ginkgo biloba, eye drops, magnesium supplement, metal-kinase, omega-7, potassium, as we mentioned, probiotic, prebiotic, vitamin A, vitamin C, vitamin E, as well as Vision Essentials Gold 3 capsules. And we include all of these ingredients, including vitamin A, C, zinc, copper, taurine, blackcurrant extract, mercury berry powder, goji berry extract, bilberry extract, carrot powder, and acetyl L-cysteine again. Schisandra berry, lutein, glutathione, so it's nothing isomers. So there is the patient's most recent labs. I think, yeah, if we just go down further,
Down. There you go.
down, please. Oh yeah, right there. You can see that. So here is the available labs for this lady. So vitamin D level was 60, which was normal. Her GFR was in the 3B, calculating with the adjusted creatine clearance. And otherwise, yeah, you have your lipid as well. I'd like to open this floor up to everyone to chime in, as well as Amy, our pharmacy students, to look into this case separately, if you don't mind coming in and doing it.
Sorry, Dr. Lee, you were breaking up. What do you want me to show?
Oh, no, that was perfect. That was perfect. So I wanted to open up. Can you hear me okay?
Okay, does anybody have any questions for Dr. Lee based on this case that has been submitted? And you can see the patient's past medical history and medications here, do you have any questions for them or have any suggestions for what they would need to do?
Hi there, this is Dr. Michelle Dossett. I am an internist and integrative medicine physician here at UC Davis, and this is not an uncommon thing for me to see. We ask our patients to bring all their supplements with them to their first visit. And, when I see something like this, the first thing I do is try to sort of understand why the patient is taking some of these different supplements, what their health goals are, what they're trying to accomplish. And then I try to educate them, and I try to remove the redundant stuff. I try to remove the stuff that's most harmful or potentially harmful, and try to simplify their regimen and working toward their health goals. So that's the approach I would take with something like this, but it's definitely challenging and it's time consuming.
Thank you so much, Dr. Dossett.
Yeah, so this is Dr. Agami. I'm the geriatrician, and actually this was one of my patients, pretty pleasant 92-year-old that just established care with UCI. Thank you, Dr. Lee, for presenting. That was a really interesting case, the patient that came with the long list of vitamins, minerals, over-the-counter, some herbal medicines, and pretty extensive for this case. It was funny that when I met her and I asked about what's the secret of being healthy at 92-year-old, almost relatively healthy, and she mentioned because I take a lot of vitamins and minerals, and I try to eat healthy. So she had a strong belief of these making her healthy, and that one of the reasons she was kept taking it and didn't want to give up, despite the expenses that was causing her son, and he wasn't happy. So when he came with her, he told us that it's causing a lot of money every month for all these vitamins. So that was the reason that first brought up. She didn't mention any of these initially, that she's taking this long list. So we just had her actual medication, and it wasn't a lot. So it took us some time to get the information. We called her back, and she had her list and this vitamin list that she was taking. So it's very important to ask about these vitamins that patients taking. Most of the time, they don't think it's a big deal, so they don't report to us. So it takes some time from us to dig into their history, what they're taking over the counter. If usually they don't know the names, they just call it as vitamins. So it's good to specify it and know. We can go through the benefits that they think that they're taking and the side effects, the risk, especially for a 92-year-old being in this expensive vitamins. So again, it was a strong belief for her. It took us some other pharmacy medicine, our fellow and myself, to go over this with the patient and take her off of it. And thank God that we've been successful about majority of these we've taken off. I usually would leave the multivitamin with the patient with the strong belief they have that they keep them healthy. It's not enough evidence that it's harmful for the patients. I keep that one for her, and for her vitamin D, wanted her to continue with that. So she ended up with multivitamin and vitamin D, and we took the rest of them off. And we tried to explain the rationale and the reason behind that. It was an interesting case.
So
A lot of money for the patient.
yeah, so can I just, my student Amy Wang, who's on this call, she actually went through all the supplements and put together a sheet that talks about adverse events and potential risks for this patient. So if you guys are interested, we're happy to share. The biggest thing in this case is there are lots of things on here that can cause bruising and bleeding. And with a 90-something-year-old, if she's at risk for falling, that could potentially be problematic. A lot of the stuff that she's on, there's really, when you look at the clinical data for it, there's not a lot of evidence for efficacy. So it's just kind of using stuff without good reason. I'm always a little worried about people taking potassium over the counter, because if you take multiple formulations with 99 milligrams of potassium, you could actually get enough potassium to cause a problem. I think 99 milligrams is about 2 to 2.5 milliequivalents per pill. So if she's only taking 99, it's probably not doing a lot. But if there are multiple sources of it, it potentially could be a problem. So that's my take on it.
Do you use Natural Medicine's database or another resource? Okay,
I love the natural database.
it's excellent. Thanks.
Does anybody have any other questions for the team?
Or yeah, if Amy would like to share with us, that would be wonderful as well.
Okay. Amy, do you want to send it to Nika and she'll forward it, right? Is that the right way to do it?
Yeah, that would be great. I can definitely add the resource into the next email that I'll send to everybody. That will have, all of our, this presentation, which we'll include in the email, and we can include that resource as well.
Sure. Okay, I will send it to you. Thank you.
Thank you so much. Okay, well, just as a closing, I will in that email also send you all the CE forms so that if you do want CME credits, please make sure you fill that out. Also, we always appreciate your evaluations. So those links will be in the email as well, again, with this presentation. Our next session is on January 21st in about a month, and it is going to be led by Dr. Gurvich again on managing depression, insomnia, and anxiety in older adults. So I hope you'll join us for that session. I know a lot of people couldn't attend today just because of the holidays, but thank you for those that did, and we have recorded the session, so we'll be sure to include it in another email that will go out next week as well. If nobody has any questions, we can go ahead and end a few minutes early. I wanted to thank you all for participating. Thank you, Dr. Lee and Dr. Argami for the case, and thank you, Dr. Gurvich, for the wonderful didactic. You all have a wonderful holiday and stay safe.
Thank you.
Thank you.
Thank you.
Thank you.